Hello students, in today's session we'll be discussing about the cardiovascular system examination. We'll be looking into how do we demonstrate the clinical signs. We have learnt about all the theory part of the clinical signs. We have looked into the abnormalities. We know the causes for various abnormalities. But today in this session we'll be discussing about demonstrations. So the demonstrations are of very much importance for your practical exams and the OSCEs that are going to be there. So today's session will be basically looking into understanding how to demonstrate these clinical signs which are going to be asked in the cardiovascular system. So when we take a cardiovascular system case which is kept for you as a long case or a short case in your exam, after you take the history you would examine, and when you present the case to the examiner, certain clinical signs will be asked to demonstrate. It could be in general physical or it could be cardiovascular system proper. So the important signs that are going to be asked for you in the examination pertaining basically is to the pulse. So we have understood about what is the pulse, how do we look for various pulses, what are the various descriptions that we do. But today we will be discussing how do we actually look for each of these. Also blood pressure, very important, the correct technique of demonstration of blood pressure. The JVP examination, what do we get clues out of that, and how do we actually measure the JVP. Now these are the important things that are going to be asked for you, and these are considered as practically basics. If you do a mistake in this, then it's going to be difficult in the exam. So you have to know, not only for the exams, for getting various clues for your diagnosis, we require to look into this. So in today's session, we are going to concentrate on the various things that they are going to ask you to demonstrate in cardiovascular system. So the first and possibly the most common thing that's going to be asked for almost every one of you is the assessment of pulse. We have learnt about when we demonstrate the pulse, we describe the pulse under various headings. We describe it under the rate, we calculate the rate, measure it for a minute and calculate it. Then we look into the rhythm of the pulse. We have discussed about it. We check whether it is regular, whether it is irregular, irregularly regular or regularly irregular. Is there any rhythm? Next is the volume of the pulse we are checking. So you are looking at whether it is a normal volume, high volume, low volume. That's what we are going to make out. Then we are going to pulse the various pulses that are there. Then we are going to check for all the peripheral pulses. So in the exam they ask you the technique of palpating the radial, the dorsalis pedis, the popliteal. So certain pulses they'll ask you to demonstrate, to palpate it. Both in medicine and surgery this is important. You look for that. Then we look for whether there is a vessel wall thickening. So whether we can make out this vessel wall thickening on examination, and how do we do that. And then we check for delays, if there are any delays or not. So these are the various things that we assess, and each of them will be asked for you to demonstrate. So once we have made the diagnosis of examining the pulse, we have to describe the pulse in a particular way. We have learnt it earlier. We describe it, for example, we can say that this patient is having a pulse rate of 70 beats per minute, which is regular, and it is a normal volume, normal character, no vessel wall thickening, all peripheral pulses are well felt, and there is no radiofemoral or radial delay. So please remember, when we describe the pulse, this is the entire description has to be there in a sentence. You have to write it in the case sheet, and when you present it you will have to tell it in this way. So only then you know that you know everything about the pulse. Again, please remember, examination of pulse is considered as very basic. You have to know everything. So coming on to the first and most common and most important thing, what you are going to do is the examination of the radial pulse. Now this, how do we do it? We have already discussed. We check it on the right side of the patient. You are standing and you are going to feel the radial pulse. You ask the patient or keep the patient's hand in semi-flexed, semi-pronated way. So you can see it in the video here, semi-flexed, semi-pronated way. and I am going to use 3 fingers, very important. 3 fingers are used. We have already discussed why we use these 3 fingers. The distal one, the one which is outside, is going to be used for blocking the backflow. So the distal one is going to block the backflow. The proximal one we are going to use for stabilizing the vessel on the bone. The bone, radial bone is here, we are stabilizing the radial artery on that bone. And the middle one is where we feel the character, we count, everything is done by the middle finger. So that's how you do the radial pulse. So as we said, the semi-flexed, semi-pronated position, and then you're going to use your 3 fingers and you're going to feel for 1 minute full. Please remember, you have to calculate it for 1 minute. You require to carry a watch which has seconds marks there, and then you're going to calculate for 1 minute, especially for the rhythm. So the rhythm you require to calculate for a minute. Rate may be 30 seconds, you might get an average rate there, but for the rhythm you will sometimes have to wait for a minute to get the abnormalities. So this is how you check for the radial pulse. Similarly, you're going to check it for the left side also. So you're using 3 fingers, please remember that. So once you have calculated the rate, you know the normal rate is around 60 to 100 beats per minute. Again, a very common question asked, what is the normal rate? So 60 to 100, less than 60 is bradycardia, more than 100 is tachycardia. We have discussed about the causes of brady and tachycardia. You could have physiological causes, pathological causes. Physiological causes for tachycardia is anxiety. If there is a stress, if there is a fever, those produce tachycardia. Pathological tachycardias are tachyarrhythmias. You could have drugs like beta agonist, etc. can cause. Bradycardia, heart rate less than 60. Physiological, sleep, athletes, you can get that. Pathologically, hypothyroidism, beta blockers, calcium channel blockers, digoxin, raised intracranial tension, obstructive jaundice, heart blocks, etc. will produce bradycardia. So you know about the theory part of it, but you have to know the interpretation, you have to calculate it. So the pulse rate is very, very important. Next is the rhythm. Again, for the rhythm, you're going to feel the pulse for 1 minute. So 1 minute, the same pulse, you're going to check in the radial pulse which we demonstrated, and then you just see whether it is regular. Most normally you have regular pulses only that's coming. It can be irregular. So where your pulse becomes irregular, we have conditions. So it could be regularly irregular or it could be irregularly irregular. Please remember the important causes. Regularly irregular is seen in case of ventricular premature complexes or ectopics. Ectopics is the most important cause for regularly irregular. It could be occurring with atrial tachyarrhythmias with a fixed AV block. Heart rate of the atria is around 200. It's a fixed block. So every third beat, fourth beat is only getting extra. That will produce a regularly irregular pulse. Irregular pulse, again the most common cause is a ventricular premature complex or ectopics. Second very important cause is atrial fibrillation. So atrial fibrillation and VPCs are causes of irregularly irregular pulse. You can get irregular pulse even in a SVT with variable blocks or a multifocal atrial tachycardia, you can get irregular pulse. So we are going to describe the pulse as it's regular or it is irregular. Okay, when we assess the irregularly irregular pulse, the most important question they ask you is how do you differentiate whether it is ventricular premature complex or it's AF. And in that condition, we calculate something called as apex pulse deficit. You calculate the apex by auscultating the heart rate in the apical impulse and then check the pulse simultaneously. Whenever we have a irregularly irregular pulse, we are going to check for something called as an apex pulse deficit. Now what do we mean by that? We check for the pulse rate as well as simultaneously check for the heart rate, and we check for the differences. So what do we do there? So simultaneously you will be auscultating at the apical area there in the heart to look for the heart rate, and you're going to check for the pulse rate, the radial pulse simultaneously, and you're going to calculate in 1 second what is the heart rate, what is the pulse rate, and you're going to check for the difference between the two. So based on that, we can have an apex pulse deficit of more than 10 or less than 10. If the apex pulse deficit is more than 10, definitely we are dealing with atrial fibrillation, and if it is less than 10, it could be atrial fibrillation or ectopics. So this is how you check for the apex pulse deficit. So Simultaneously, you are going to look for the apical or the heart rate and the pulse rate. So the very important question that they ask you is the difference between atrial fibrillation and VPCs clinically. So apex pulse deficit, I told you. Atrial fibrillation, the apex pulse deficit is usually more than 10, whereas ventricular ectopics, it is usually less than 10. A wave in the JVP, if you are able to see, that means atria is contracting properly. So in atrial fibrillation, J wave, A wave, in the JVP, the A wave is absent. So in atrial fibrillation, the A wave in the JVP is absent, whereas in the ventricular ectopics, it is present. Next, coming on to the first heart sound. Remember, in atrial fibrillation, the contractility of the ventricle will be varying intensity. So first heart sound classically is varying. So whenever there is atrial fibrillation, we say S1 is varying in intensity, whereas in ventricular premature complex, S1 is normal intensity. Next, the simple thing that we can do is, if you find a pulse is irregular, just ask the patient to walk a small distance and come back, check for the pulse again. Now the pulse can become regular, that means the irregularity was due to ectopics. Whereas if the pulse is irregular even after exertion, that means it is atrial fibrillation. So atrial fibrillation, exercise or just a simple isometric hand grip. Patient with cardiac disease, you can't ask them to walk, you just ask them to do a hand grip. Now the hand grip in case of atrial fibrillation will still keep the pulse irregular. So pulse rate will always remain irregular in case of atrial fibrillation, whereas ventricular ectopics, the pulse rate or the rhythm becomes normal or it becomes regular. This is a very important and a simple thing that you can do to see whether it is atrial fibrillation or VPC. Always remember, ectopics happen in the refractory period, and when we exercise or we do a hand grip, the heart rate increases, and when the heart rate increases, the refractory period decreases, and since the ectopics come under the refractory period, the ectopics will no longer be able to come and the pulse will become regular. So this is very important difference. This is always asked for you. Apex pulse deficit is important, but please remember, sometimes atrial fibrillation patients are already on treatment. They are on beta blockers, calcium channel blockers. The heart rate would have come down. So their apex pulse deficit can be less than 10 also. But VPCs is always less than 10. So this differences you have to remember. Next, coming on to the volume of the pulse, we always described the pulse volume is the height. So always we know the topmost point represents the systolic blood pressure, the bottommost point represents the diastolic blood pressure. So the volume of the pulse is nothing but the measure of pulse pressure. So as we say, the normal volume, high volume, low volume is always objectively measured by checking the blood pressure. So if I say this patient has a high volume pulse, that means the pulse pressure should be more. Remember, the normal pulse pressure 120 by 80. So the normal pulse pressure is around 40 maybe. So you can say it is 40 plus or minus 10 maybe. So in such conditions, if the pulse pressure is less than 30, we call it as a low volume pulse. If it is more than 50 or 60, then we call it as a high volume pulse. So whenever we say high volume, you should have an objective evidence when you check the blood pressure that you should have a wide pulse pressure. All of you know about the abnormalities. You have high volume pulses, which we call it as a pulsus magnus, sometimes we call it as collapsing pulse, classically seen in high output states, mitral regurgitation, aortic regurgitation, patent ductus arteriosus, you get high volume pulse. The low volume pulses, shock, heart failure, mitral stenosis, aortic stenosis, you have a low volume pulse that is seen. So it is very important that we have to give importance to the pulse rate, rhythm and volume. Based on the rhythm and volume, we can narrow down the valvular heart diseases that we have. The common valvular heart disease that we have, you have mitral stenosis, you have mitral regurgitation, aortic stenosis and aortic regurgitation. Isolated valvular heart disease, sometimes and most often you might get combined, but I am talking about the isolated valvular heart disease. Please remember, atrial fibrillation is classically because of the enlargement of the left atrium, and that is more commonly seen with mitral valve disease. So atrial fibrillation is seen with mitral valve disease more commonly. Aortic valve, it is little rare. So in case of mitral valve disease, be it MS or MR, we get atrial fibrillation, so you can get an irregular pulse. Aortic valve disease, irregularity, atrial fibrillation is less likely. So, volume of the pulse, we have already discussed high volume pulse, AR and MR, low volume pulse, MS and AS. So, if you take the combination of a high volume, regular pulse, high volume we said it is MR or AR, regular it is always aortic valve. So, the answer here is aortic regurgitation. You have a high volume pulse but it is irregular, that means this patient has atrial fibrillation, more common with mitral valve disease, and it is a high volume, so it is MR. So, MR has an irregular high volume pulse, AR has a regular high volume pulse. Now, coming on to the low volume pulse, the two valvular heart diseases that we have, AS and MS. Regular aortic stenosis, irregular mitral stenosis. So, by looking at the pulse rhythm and the volume, we can narrow down our diagnosis to some of these possibilities that is there. So, that is how you can, the pulse, if you examine carefully, you can narrow down the valvular heart disease. Coming on to the character of the pulse, this is generally best appreciated in the carotid, and then the normal character of the pulse is what we call it as a catacrotic pulse. We have already described the generation of the pulse. Why do you get the various waveforms in the pulse? You have the forward percussion wave, which is due to the distension of the aorta, and then the reflected waves which come from the upper limbs, which produces the tidal wave, and then the dicrotic notch, which is due to the closure of the aortic valve, and then the dicrotic wave is because of the reflected waves which are coming from the lower limb. So, at various points we can get various abnormalities that you can get in the pulse. Now, when we look at the pulse abnormalities, the character abnormalities, again we can consider our differences based on a high volume pulse or a low volume pulse. So, when we assess the character, again it is easier for us to do it if we have based on the volume. So, we could have pulses which are high volume and we could have pulses which are low volume. So, if you see the high volume pulses, all of you know how to check the high volume because we have already said the pulse pressure is more than 60. Now, high volume pulses, what we call it as the pulses magnus, that would be the most important one, the very big volume pulse which would be there. Under that, you could get certain types, like you could have a collapsing pulse or what is called as the water hammer pulse. That could be thing. Also, to certain extent, the pulses bisferens comes in the high volume. Now, when we check the low volume pulse, otherwise called as the pulses minimus, you could get the anacrotic pulse which we see in aortic stenosis, the pulses parvus et tardus, again we see it in aortic stenosis. You can also get the pulses alternans, the alternating wave is low volume. So, the low volume or high volume can get you certain characters of the pulse. So, we have discussed about each of these characters in detail in the earlier sessions. Now, let us go on to look into how to demonstrate. The most important one they ask you in exam is how to demonstrate this collapsing or water hammer pulse, which is classically seen with aortic regurgitation. So, what do we do? So, you start checking it. I told you all the characters are better felt in carotid except for certain like the collapsing pulse, which you require a distal pulse. So, you are starting feeling the radial pulse, you start feeling it and keep coming proximally till it is just felt. So, you are going to go back and back till it is just felt. So, at some point it is just felt, that point we are going to choose. Now, at the point where it is just felt, you are going to place your metacarpal heads, this part of your hand, you are going to place it there. Always remember, in cardiology, the metacarpal heads are used for thrills. So, you are going to place the metacarpal heads there, and what you are going to do next? You are going to hyperabduct the arm and raise it above the shoulder. So, you are going to place the metacarpal heads there, and then you are going to hyperabduct the arm and raise above the shoulder. Simultaneously, with the other hand, you are going to encircle the wrist. So, simultaneously with the other hand, you are going to encircle the wrist. So, with this hand, you are going to feel for the radial and ulnar, whereas with the other hand, you are actually feeling the brachial or the distal part of the radial that you're feeling, where the backflow will happen. Now, when you're doing that, and then you're going to hyperabduct the arm and raise it above the shoulder. So that's what you're going to do. You're going to hyperabduct the arm and raise it above the shoulder. Now, what does normally happen? Now, normally you can feel the pulse here. As you go proximally, you will not be able to feel the pulse. But in condition where this, you see it in this condition is aortic regurgitation, you will get a bounding pulse. Large amount of blood is coming forwards, and to accommodate it, your peripheries are open up. There is vasodilatation. So, large amount of blood will go to the peripheries. So, you will see the bounding pulses. Even the ulnar artery you can feel in aortic regurgitation. Normally, we don't feel it. So, when we raise the arm, normally the pulse volume should decrease. But in aortic regurgitation, what happens? The pulse volume will still be present. And as you raise the arm, why do you raise the arm? Because you want to make a straight line. You are keeping the radial, brachial, axillary, and then the subclavian, etc. in a straight line. Okay, the entire blood column comes back into the aorta. So you find a sudden gushing down, and that is what you will feel on the metacarpal heads. You will feel that the blood is going down like this. So that is why we keep this arm here, where you will feel some sort of a thrill of the blood going back. Now that is what we call it as a water hammer. So you can see the demonstration here. You are feeling the radial artery. You are going backwards till it is just felt. And there at that point you are going to place your metacarpal heads and then encircle the distal part, raise it above. In a patient with aortic regurgitation, you will feel a flow like this or a thrill which is passing like that, which is classically called as the water hammer pulse. So you are feeling it, go as distally, play the metacarpal head there, and then hyperabduct and raise the arm above the shoulder. This is best done in sitting position, but it can be done in semi-recumbent positions also. In the supine position, it may not be so evident. Water hammer pulse classically seen with aortic regurgitation only, because that column of blood has to go back to the ventricle. The valve should be incompetent, otherwise you won't be able to demonstrate it. You can get high volume pulses with aortic regurgitation, mitral regurgitation, high volume states, but the water hammer is characteristic of aortic regurgitation. There are other pulses which sometimes they ask you to demonstrate is the pulsus alternans. Now pulsus alternans and pulsus paradoxus, these two pulses are difficult to demonstrate because these are seen in patients who are absolutely sick. So it's very difficult to demonstrate it, and both of these alternans as well as the paradoxes require a sphygmomanometer. You will require a BP cuff to demonstrate. So pulsus alternans classically seen with acute left ventricular failure. Now when there is an acute left ventricular failure, the cardiac output decreases. So you get a low volume pulse that you get. What happens? Blood is remaining in the ventricle, stretches the ventricle. So the next beat is going to be strong. Again the next beat is going to be slow, next is going to be strong, next is going to be low. So alternating high and low volume pulse. Okay, so that's what you get in case of pulsus alternans. Now how do we do it in a patient? You tie the BP cuff and then we are going to raise it above systolic. So if you see this diagram, this is how an actual pulsus alternans. It is better seen on a monitor rather than clinically. So you see this high level here and the lower. I told you this is the systolic blood pressure and this is the diastolic blood pressure. Let me give an example. I write this value as 100 and maybe the lower part I am writing it at 60. Now I have raised the blood peep to 120 and now I start decreasing slowly. I have come to 100. Now when I reach 100, what will I start hearing? When I am hearing the corticoff sounds, I am auscultating, I start hearing this, I start hearing this, I start hearing this, I start hearing this. So I get a n number of corticoff sound, right? Now as I lower it further, possibly at around 90 millimeters of mercury, what should I start hearing? Now at 90, I will start hearing the lower volume pulses also along with the higher volume. So I get hearing this, 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 this and this. So I am hearing all the sounds. So a sounds which were possibly 4 now have become 8. So I start hearing the doubling of the corticoff sounds. So when I am auscultating, I get one sounds, it's just beating like that. And as I come lower, I start doubling of the corticoff sounds. That is how you diagnose pulsus alternans. It is difficult to demonstrate it because the patients are sick, and per se, in case of acute LV failure, the BP itself is very low. So to demonstrate this difference may be practically not possible. It's more recorded on a manometer or maybe on your monitors that we do. The next pulse is the pulsus paradoxus. Now again, a very important, lot of MCQs are asked on pulsus paradoxus. You should understand that this pulsus paradoxus again very difficult to demonstrate because this is seen in patients who are very tachypnic. There is acute severe asthma, acute exacerbation of COPD. These are two common conditions where you can get pulsus paradoxus. But classically pulsus paradoxus is described for constrictive pericarditis. Now here again is the blood pressure that we are seeing. Normally when we inspire, the blood pressure falls a little. That's what we see. So physiologically, the first Korotkov sound, if you start measuring the blood pressure and start slowly lowering the BP, the first Korotkov sound should be always in expiration. That's what you have to remember. The first Korotkov sound is always in expiration. As you lower the blood pressure slowly, you will start hearing it both in expiration and inspiration. Both in expiration and inspiration. So that is a physiological, normal, that is how it is. Usually the gap between this is not more than 2 to 4 millimeters. So clinically we may not be able to make out if you do it fast. But always remember, expiratory blood pressure is higher. Now supposedly this gap falls for more than 10 millimeters. It becomes wider. That means you are hearing an expiratory blood pressure, get it lower, still you are hearing only expiration. Inspiration only comes at much lesser. The Korotkov sound will not be heard in inspiration. So till a lower blood pressure, that gap if it is more than 10, that's when we call it as pulsus paradoxus. Now how do we demonstrate it? Again, you require a BP cuff. Very, very important. You should not make the patient conscious that you're checking for the respiratory variation. Because even if the slight awareness happens, this normal physiology goes off. You can't ask the patient to take a deep breath, deep inspiration, deep expiration. No instructions, very important. Do not give any breathing instructions to the patient. Do not give any breathing instructions to the patient. That is very, very important. So you're not going to give any breathing instructions. You're just observing the patient. Tie the BP cuff and then get the systolic, go above systolic and start slowly lowering. Now you will hear the first Korotkov sound. First Korotkov sound is heard. Just stop there. Observe the patient. Inspiration, expiration. What should happen normally? Normally the first Korotkov sound should be only heard in expiration. Should not hear in inspiration. Right? That should be normal physiology. Start slowly lowering. At a lower blood pressure, you will start hearing both expiration and inspiration. Now measure the difference. Usually it's less than 10. That is normal. Now supposedly first only you get both inspiration and expiration, that means you're run around, you'll have to go a little higher. The first Korotkov sound is always heard in expiration alone. Now supposedly this gap becomes more than 10. So inspiration is here and expiration is more than 10 gap if it comes. That is what we call it as a pulsus paradox. Again, please remember it's a misnomer. It is not a paradox. It is an exaggeration of the normal phenomena. So it's an exaggeration of normal phenomena. Again, difficult to demonstrate, but you get a lot of questions of this. This can be demonstrated only by using a sphygmomanometer. So after the character of the pulses, the various abnormalities of characters we have learnt in theory, various characters, various diseases, you have to know it by heart. A lot of MCQs are asked on that. Condition of the vessel wall, we check by doing something called as an Osler's sign. Now what we do is, we have to empty the blood vessel, only then can we feel the vessel. So tie the BP cuff, raise it above systolic, there is no blood flow here. Now you roll your fingers on the artery. If you feel a cord-like sign, that is sign of vessel wall thickening or arteriolosclerosis. So small vessels, arteriolosclerosis, that is a sign of pseudo-hypertension. So Osler's sign or Osler's maneuver, this is what we call it as an Osler's maneuver. It's a sign of pseudo-hypertension. That's how we look for vessel wall thickening. So empty the vessel, roll, and you will be able to make out. Next thing, very, very commonly we ask in exams is to demonstrate the various peripheral pulses. Both in medicine and surgery, we are asking you to demonstrate. So starting from the important pulses, the central pulses, the carotid, brachial, radial, femoral, popliteal, dorsalis pedis, posteriotibial, superficial temporal. All these pulses, you should be knowing the correct technique of palpating. One important thing you remember, that all pulses are felt with 3 fingers, ideally, because that character is what we described that time, except for the carotid. Carotid is best felt with the thumb, okay? The right thumb for the left carotid, left thumb for the right carotid. That's one thing that you have to remember. You can feel the carotid with 3 fingers, nothing wrong, but thumb is what we use. Next, all pulses you can feel simultaneously. Right side and left side you can feel simultaneously, except for the carotid. Carotid you should feel one at a time, because supposedly you compress both the carotid, it can cause problems. So carotid is one pulse which you should not feel together. It has to be felt one at a time. So the first pulse we are going to look for is the carotid. So it's an important vessel there in the neck. So what is the surface marking? Please remember, it is on the superior border of the thyroid cartilage, on the anterior border of the sternocleidomastoid. You're going to press against the transverse process of the cervical vertebrae. So that's how you're going to do it. In front of the patient you're going to stand, left hand for right carotid. So this is what you're seeing here. The right carotid I'm feeling here with the left thumb. You can feel it with 3 fingers, no harm, but then we are going to feel it with 1 thumb. So you're going to feel, put your hand there and palpate it. That's how you look for the right carotid. Now if you go on to the left carotid, we are going to feel with the right thumb, again on the anterior border of the sternocleidomastoid, at the superior border of the thyroid cartilage, you are going to feel it. Always, after you feel it, auscultate the carotid for bruise. Very important, auscultation for bruise. Especially in stroke patients, you have to look for carotid bruit and sometimes the vertebral artery bruit also. Okay, the next most important vessel which you are going to look for is the brachial artery. So where do we feel the brachial artery? It is medial to the biceps tendon. So always ask the patient to flex, feel the biceps tendon, and you're going to go medial to that. On the right side as well as on the left side, please remember the brachial artery is always medial. Medial is inside. Right side you always do it correctly. When you go to left side you get confused and you put your hand laterally. Remember, it is medial to the biceps tendon. That's how you look for the brachial artery. You can use 3 fingers for that. Radial artery we have already felt. Next, coming on to the femoral artery. In surgical cases, peripheral vascular disease, they always ask you midpoint of the inguinal ligament. So look at the pubic tubercle, look at the ASIS and identify the midpoint. Keep your fingers there, look for that. So femoral is a very big vessel. You can auscultate for bruise on the femoral also. So you're going to look for the femoral. Next, very common thing asked is, how do you feel for the popliteal vessel? Now again remember, popliteal you have the fossa which has 2 triangles, one up and one below. Remember, the popliteal artery is felt in the lower triangle, not in the upper part, it's felt in the lower triangle. Now you're going to use both your hands. Your thumbs are on the tibial tuberosity and your entire other fingers are inside the popliteal fossa. You're feeling the artery in the lateral part. The artery is felt in the lateral part. You can see here what we are doing here. Here you're keeping the thumbs on the tibial tuberosity. Artery is always felt on the lateral part in the lower part of the popliteal fossa. Please remember, it is not in the upper triangle, it's in the lower triangle. It is in the lateral part of the lower triangle. Very common asked in the exam. Next, coming on to the posterior tibial pulse. Posterior tibial is felt behind and below the medial malleolus. A centimeter behind and below the medial malleolus. So again, medial malleolus is inside, not outside. So it's not lateral malleolus, medial malleolus, behind and below the medial malleolus. Somewhere in between the Achilles tendon and the malleolus, midway you can feel. That's where we feel the posterior tibial, very important vessel. Next, again, the most common asked in the lower limb is the dorsalis pedis. Now dorsalis pedis is felt lateral to the EHL tendon. So look at the EHL tendon, lateral to the EHL tendon, not in the distal portion, it's somewhere in the proximal part you're seeing. You're making sure the EHL tendon is seen. Lateral to the EHL tendon, somewhere proximal, you can compress it on the navicular bone. And dorsalis pedis is a very common artery. You have to check it in all patients. Dorsalis pedis absence could be physiological above the age of 65 Almost 5 to 10% of the population may not have a dorsalis pedis, but in a cardiac case, absent dorsalis pedis would indicate a embolic phenomena. So it's very important that you feel for the dorsalis pedis pulse. The superficial temporal, again remember, superficial temporal artery is not present in the temporal fossa. It's present in front of the tragus. So in front of the tragus, you're going to feel the superficial temporal artery in front of the tragus. And very important, elderly persons coming with headache, you have sometimes can feel a cord-like temporal artery. This is classically seen in giant cell arteritis or temporal arteritis. Sometimes they may ask you to feel for the subclavian artery. Please remember, the subclavian artery is felt in the supraclavicular fossa. The entire supraclavicular fossa, the subclavian artery is there. First part, second part, third part, you can feel the various pulses. So this is how you look for all the pulses. Please make a habit of checking for all the pulses in all the patients. Only then can you identify whether they are present, absent, whether it is normal, abnormal. The next thing that you look for is the radiofemoral delay. Classically you get in case of a coarctation of aorta. So you simultaneously feel for the radial and the femoral. You're feeling the radial and femoral simultaneously. Normally, please remember, the femoral comes faster. Femoral is a bigger vessel, direct communication of aorta compared to the radial. So femoral comes a little faster. So it's never together. So how do you identify that the radiofemoral delay is there? In coarctation, femoral is delayed. Both the pulses coming together is abnormal. To identify which is coming first, we will have to time it with the carotid based, or the S1, you time it with the S1, which comes first after S1. Femoral should come. So in coarctation of aorta, both the pulses come simultaneously. Sometimes you can get it in other conditions like some aorta arteritis or sometimes tuberculosis which affects the aorta, what we call it as a middle aortic syndrome. Sometimes you can get this phenomena. Radio-radial delay, simultaneously feel the radial arteries. Both should be coming together. Sometimes one radial might be delayed. It always points out to a local cause, a thoracic outlet obstruction, either due to a cervical rib or a lymph node or a tumor sitting there. That's the common cause of radio-radial delay. Sometimes what we see is the volume of the pulse in the right radial is more than the left radial. Okay, the volume is stronger. The blood pressure also is little stronger. What we call it as an anisospigmia. That means the upper limb blood pressures are changing or different. This is classically seen in a condition called as supravalvular aortic stenosis. We get in a syndrome called as Williams syndrome. What happens in Williams syndrome is there is a selective jet of blood from the aorta is directed towards the right subclavian. So the blood flow, though the blood is coming together, the jet is directed towards the right. So the volume, the pressure and volume is little more on the right. So this effect is what we call it as the Coanda effect. So that is called as the volume in the upper limbs can be varying. It's a rare phenomena. That is what you have to. So this is how we discussed about the pulse. Please remember, students, that the pulse is going to be asked for you. Each one of you are going to be asked one component of pulse in examination. It's of very, very, very important. It is considered as basic. If you make a mistake in this, it is unpardonable. The next important thing is the blood pressure. Again, we have discussed the theory of the blood pressure, how do you measure it, all the theory part of it we have discussed. But again, blood pressure is an important OSCE station which they are going to keep it. You know, with the new curriculum, we have a lot of OSCEs going to come, and blood pressure is one of the common OSCEs that is going to be checked. And they are going to just observe you, no instructions, no questions asked, just observe how you do it. And blood pressure is a very, very common OSCE station. So you should be very clear in how do you do that. We have discussed already how to check the blood pressure in an office blood pressure, how do you tie the cuff, where do you tie, patient in supine, sitting, all those positions. But certain prerequisites I am going to emphasize here. Always remember, in your exam, you're going to check the blood pressure in supine patient. And we can't have this typical office setting where you sit with the patient quietly for a given time, and then patient should not have coffee, there should not be anxiety, all those things. It is not possible in the exam hall. So exam hall, when you check the blood pressure, we are going to observe how are you going to tie the cuff, where are you going to place the tubings, how are you going to check the systolic, how are you going to do the diastolic, and how do you check a recording. That is how we are going to analyze you. So how are you going to place the cuff? So please remember, patient in supine position, we normally check on the right radial artery, you can check it on the left also. How are you going to place the cuff? Very important point you should always understand. The cuff has a bladder. Bladder is having the tubing. The tubing which you are going to use, the tubings which you are seeing there, tubings should be parallel to the brachial artery, and preferably they should be medial to the brachial artery. So it should be kept in such a position, the tubing should lie parallel to the brachial artery, preferably medial. Okay, so the bladder should be there, that's where the compression would happen. And if you see the distance, at least 2 fingerprint distance should be there above the cubital fossa. And always very important, once you have tied this, place the BP cuff or the BP apparatus next to the patient, parallel to the patient, there itself, that's the heart level. And then check the systolic blood pressure by palpatory method. This is very important. Many times you forget this, you are checking the systolic blood pressure by palpatory method. Now it is very important that this palpatory method, if you miss and directly go to auscultatory method, you might get a wrong reading, okay, because of something called as an auscultatory gap. We have discussed about it. So always systolic blood pressure is got by palpatory method. Now once you have got the systolic blood pressure, then we are going to auscultate and get the diastolic blood pressure. Again, please remember, when you auscultate, raise it above systolic, slowly start getting down, check the systolic as well as diastolic, and then record it. Once you have recorded it, you can take a mean of 3 values. Sometimes in atrial fibrillation, you are expected to take 3 values because varying volume of pulse is there, varying carotid cough sound will come, you are expected to take 3 values. In cardiology cases, you are expected to take the BP of all 4 limbs. The left limb, you can use it in this same only, but for the lower limb, with this cuff, we cannot tie this cuff in the thigh because this is too small for that. With this cuff, we can only measure the cuff. So tight at the cuff, palpate the dorsalis pedis and get only the systolic blood pressure. Please remember, in the lower limb, never mention a diastolic blood pressure with this cuff, because for the cuff to tie it on the thigh, we require a big one, usually not available. So there you can auscultate the popliteal and get both systolic and diastolic. When you tie this cuff into the calf, you are going to palpate the dorsalis pedis or posterior tibial, you are going to get only systolic blood pressure. And whenever you are doing an OSCE, make sure you tell the value to the patient, document in the case sheet, thank the patient, take the consent and thank the patient, all those things you are supposed to do. Blood pressure examination is of that paramount importance. Okay, this is some things which can pass and fail you. If you do not know the blood pressure checking properly, they can actually fail you straight for that. So you have to give good importance to the blood pressure. Also, sometimes in elderly patients, you are expected to check for the postural blood pressure. They may just keep an OSCE station, examine the blood pressure of this 70-year-old man. So you're expected to check the sitting and the standing, because elderly people are more prone to hypotension, especially when they stand up, postural hypotension. So you're expected to do that also. Make the patient stand for 3 minutes and check the blood pressure. If there is a systolic drop of more than 20 or diastolic drop of more than 10, we call it as postural hypotension. So all this is very important with the BP recording. The next important sign that we look for is the jugular venous pressure, the JVP, the measurement of the JVP and the abnormalities. We have discussed the theory part of it already. How do you identify the JVP? What are the differences between JVP and carotid? Now what is very important is how do we measure the JVP? So all of you know we require 2 scales. Again, we require long scales, not the small ones. First and most important is we are going to identify the uppermost level of the JVP in a patient with 45 degrees, and we are going to place one scale. The first scale we are going to place parallel to the ground, not parallel to the patient, parallel to the ground. And the second scale we are going to keep it at the sternal angle perpendicular to the first scale. That's how we are going to place. So of paramount importance is to identify the upper level. Now how do you identify the upper level? Very simple thing you can just do is what we do, an abdominojugular reflux. So you press in the abdomen, preferably on the right side. Earlier it was called as an hepatojugular reflux, now we call it as an abdomino. because we are going to press not the liver, we are pressing on the IVC. So you just press it on the IVC, blood will increase to the right atrium and right atrium pressure will get transmitted to the JVP. You will see the elevation. So you can see that in this video. So you are looking at the neck here and you are seeing some waves, you are not sure whether it is JVP or not. You start giving a firm pressure in the hypochondrium and you can very nicely see the pulsations there. So that's how you identify. Now, what is this abdominojugular reflux? As we said, by compressing, we are increasing the pressure in the right side, right atria. Now remember, a normal heart will compensate. It will compensate. How fast? It compensates within 5 to 6 cardiac cycles. So within 5 seconds, 4 to 5 seconds, the JVP will fall. The rise JVP will fall. That's physiological. Now by doing the abdominojugular reflux, we are checking the patency of the IVC up. Sometimes you press, there is no JVP rise. What does it indicate? That there is no patency. It might indicate a Budd-Chiari syndrome. Sometimes you press and the JVP rises and it remains elevated. 5 seconds, 6 seconds, 10 seconds, it has remained elevated. What we call it as a sustained abdominojugular reflux. Now that is characteristically seen in right heart failure. So heart failure, incipient right heart failure. Before the other signs of right heart failure, JVP has not elevated, pedal edema has not come. Just give a compression. Sustained abdominojugular reflux is a sign of incipient right heart failure. So you have to remember that this is the abdominojugular reflux, and that is one of the simple ways to identify the uppermost level of the JVP. Please give very good importance to JVP and measure the JVP properly, because that gives you a lot of clue for your diagnosis. And quite a lot of patients do have JVPs, so don't miss that. Always examine the neck of the patient. So this was about the general examination in cardiovascular. Next, coming on to the cardiovascular system per se. Please remember one golden rule: always time whatever you are looking, palpating, auscultating, everything with the carotid, because carotid stands for the first start sound. So based on that we know systole and diastole. So whatever comes synchronous with the carotid is systole, asynchronous is diastole. Now what are the things they ask you to demonstrate in the cardiovascular system? The two important things which is often asked is the apical impulse and parasternal heave. Sometimes they ask you for epigastric pulsations, other areas, percussion of heart, that is what is asked. But two very common things that is asked is apical impulse. So always remember apical impulse. That's the first and most important thing. When you look for the apical impulse, always feel on the left side, feel on the precordium with the full hand, and then localize with the border, and then with one finger you have to localize the apical impulse. So you are going to localize the apical impulse very in a point. So how do we do this? So this is the video. First you put your full palm there, feel for the pulsations, then try to get it further narrowing, and then finally you are going to point out with one finger. Always remember, apical impulse will give you all the clue whether there is cardiomegaly or not. Normal apex, 5th intercostal space, left side, half an inch medial to the midclavicular line. Is it shifted? That means there is a chamber enlargement, left ventricle is enlarged. Is it a hypertrophy or a dilatation? If it's a dilated heart, apex will be diffuse, occupying 2 spaces or more. If it is a hypertrophy, localized apex. So, position of the apex will tell you some things. Next, you feel for the character of the apex. You feel and confirm the character of the apex. The normal apex is considered as mildly tapping or normal. It could be tapping when it comes nicely and hits your finger and goes. Classically seen with mitral stenosis. It's a localized apex. Next, it comes, hits your finger, raises your finger and goes. Remains in contact with your finger for a long time. At least 2/3 of the systole. We call it as a heaving apex. Heaving apex means LVH seen with hypertension, aortic stenosis. Next type of apex is what we call it as a hyperdynamic apex, which is forceful, but it is ill sustained and it is diffuse, occupies more than 2 intercostal spaces. This would indicate LV, volume overload, dilated ventricle, occurs in MR and AR. So by looking at the position of the apex, the character of the apex, we can localize our valvular heart disease. Tapping mitral stenosis, heaving aortic stenosis, hyperdynamic, MR or AR. So apex is of very importance there. Next, that's about the left ventricle we see. The right ventricle you can make out by looking at the left parasternal heave. So left parasternal heave can be felt by two techniques. One is by keeping the ulnar border there, or else keeping the cocked up palm. So palm cocked up like this, you keep it. So this is how you look for. So this is how I am placing on the left parasternal region. I am placing the cocked up palm, or I am placing the ulnar border. So that's how I looked for it. So the cocked up hand on the left parasternal region and the ulnar border, both can be used. Now this indicates RVH. So whenever parasternal heave is there, it's more likely to be an MS or an MR, less likely to be an aortic valve disease. That is what you have to remember. Small amount of parasternal heave or pulsations can be detected by placing a pen, but that's seen usually in children. Just place a light pen there, it will rise up. So you have to feel for the parasternal heave and pulsations and grade it. You have a grading of 1, 2 and 3. So grade 1 is visible, not palpable. Grade 2 is visible, palpable and obliterable. And grade 3 is visible, palpable and not obliterable. So these two common things they ask you, how do you look for the apical impulse? How do you look for the parasternal heave? Apical impulse is left ventricle, parasternal heave is right ventricle. Rarely parasternal heave can be due to left atrium also. When you have a big left atrium MSMR, you might get a parasternal heave because of that. Next is the epigastric pulsations. Now again in the epigastrium, the cardiac chamber which can be felt is right ventricle. But remember in the epigastrium you can have aorta also. So you feel the epigastric pulsations by using your thumb. So you place the thumb in the epigastric region there below the xiphisternum. Ask the patient to hold a deep breath so the diaphragm comes down. So you might feel the impulse on the tip of your finger. If you are feeling it on the tip of the finger, it is right ventricle. If you are feeling it on the pulp of your finger, it is aortic. So whenever we see the epigastric pulsations, if it is felt at the tip, it's always right ventricle. If it is felt as the pulp of the finger, it is aorta. So this is one more thing that you have to feel, epigastric pulsation. Again in cardiac, all other areas you have to palpate. You might be able to palpate the sounds. You may be able to palpate the second heart sound in the pulmonary area. You may be able to palpate sometimes the S3 or S4 also can be palpated. So other than that, you can palpate the murmurs, what we call it as the thrills. So always remember the thrills are better felt at the metacarpal heads. You place it like this and based on the murmur, systolic or a diastolic murmur, you will be able to feel the thrills. Next, sometimes they ask you, sometimes good students or maybe in respiratory system they ask you is the percussion of the heart border. Now again remember in cardiology, border percussion is not of importance because by percussing the heart border, you have to make out whether there is cardiomegaly or not. Now cardiomegaly you have already made out by looking at the position of the apex. So the percussion doesn't actually aid, but you should know the technique of percussion. So you percuss for the right heart border and then you percuss for the left heart border, and based on that you can make out whether the heart is enlarged or not. So for getting the right heart border, you start percussion from the second intercostal space, come down till you get the liver dullness. So you have to come till the liver dullness because that's where the diaphragm is and that's where the heart is located. And then you go one space above and now turn your direction of percussion towards the heart. Remember the heart border is like this. So you are going to go parallel to that. Your direction of percussion will be like this. So if you see it in this video, I am starting percussing from the second intercostal space downwards till I get the liver dullness. Now once I get the liver dullness, I know that the diaphragm is there. So that's where I got the liver dullness. I stopped there, went one space above and then turned my hand and started percussing from mid-clavicular line to the right sternal edge. So I do it in one space, mark that point, go to the next space and mark that point again there and go to the next space and mark that point. So when I get these 3 points, that is the right heart border. So please remember, this is how you do the right heart border percussion. Again I am demonstrating it. I am going to percuss from the second intercostal space downwards till I reach the liver dullness. Once I reach the liver dullness, I am going to go one space above one space above, and then I am going to turn my hand, and direction of percussion now will be from lateral to medial towards the cardiac border. The normal right heart border corresponds to right sternal edge. Right heart border corresponds to right sternal edge. Coming on to the left heart border. Now how do we look at the left heart border? Always remember, feel for the apical impulse, feel the apical impulse, and wherever the apical impulse is, go to the anterior axillary line. So if it is in the fifth space, go to the anterior axillary line and then start percussing from outside to inside. One point you should always remember, the left heart border is not straight. See, right heart border was straight like this. Left heart border is diagonal. So your direction of percussion also should be parallel to that. So you have to keep your fingers. You can see that in this video, how I have kept the finger. It is diagonal or parallel to the heart border. Since the heart border is like that, my percussion will always be parallel to that. So normally the left heart border corresponds to apex. Left heart border corresponds to apex. Now as I told you, cardiac percussion is not much of use in cardiology, but in respiratory system, cardiac dullness may be obliterated in emphysema. Sometimes pericardial effusion, you might have a cardiomegaly outside the apical impulse. One important thing they ask you is the percussion of the pulmonary area. Left second intercostal space pulmonary area is normally resonant, but if there is a pulmonary arterial hypertension, you get dullness. You can actually measure the dullness there from the lateral sternal edge, how much dullness is there. So left second intercostal space is dull. It indicates pulmonary arterial dilatation, pulmonary arterial hypertension, aneurysmal dilatation of the pulmonary artery. So left second intercostal case percussion is important. So this is about percussion. Next, coming into auscultation, again remember auscultation is the least important thing when you examine the patient. Though you can get some particular findings only on auscultation, but you can make a reasonable diagnosis before you arrive at auscultation. We have discussed the theory of the auscultation, what we look for. We look for the heart sounds. We look at the normal heart sounds. So you have S1, then you have the A2, P2. So what is between S1 and S2 is the systole, and after that is the diastole that is there. You can have the additional sounds that could be there. You have the opening snap in diastole, you have S3 in diastole, you have the S4 presystolic. Sometimes pericardial knock is just heard around the opening snap there. In the systole, you can have clicks, ejection clicks and the non-ejection clicks can be there. So various sounds can be there. So always time it with the carotid, look for the sounds. We have discussed the theory of it. What do we, S1 is produced due to what? How is S1 loud? What are the factors? All these things we have already discussed. In second heart sound, we look at the intensity. We look at the splitting of the second heart sound, very important. And then we look at the various abnormalities, S3, S4, opening snap, what are the characteristics. Now the technique of auscultation for sounds, remember the soft sounds, that is the S3 and S4 are auscultated with the bell. Whereas all the other sounds, be it the opening snap, S1, the ejection click, the non-ejection click, all are auscultated with the diaphragm. For S3 and S4, we have to use the bell. That is one thing you have to always remember and time with the carotid. Now in the exam, they ask you two things in auscultation. Is the technique of auscultation for mitral stenosis. Remember in mitral stenosis, you get a mid-diastolic murmur in the mitral area. It's a soft. So what we use the bell of the stethoscope. So you're placing the bell in the mitral area, timing with the carotid, ask the patient to turn to left lateral position. Hold the breath in expiration. Remember. So mitral area, bell, expiration, left lateral position. Very important. This is how you auscultate for mitral stenosis murmur and you get a mid-diastolic murmur. Next murmur they commonly ask is the aortic regurgitation murmur. Now aortic regurgitation murmur, you are going to auscultate the aortic area with the diaphragm. Patient in sitting and leaning forwards. What we call it is an Erb's maneuver. Patient leaning forward, sitting and leaning forwards. And you are going to time it with the carotid. So what do you hear? You hear an early diastolic murmur. So please remember, these are two common things that they ask you in the examination for auscultation. Auscultation for OS is always with diaphragm. Auscultation with S3 is with a bell. Auscultation for mid-diastolic of mitral stenosis, bell. All other murmurs is with diaphragm. So mitral area, left lateral position. Aortic area, sitting and leaning forwards. Both the murmurs, expiration. Always time with carotid. This technique has to be done proper because what you hear, we cannot make out. What you hear is your only hearing. We cannot hear that. But the technique what we use for demonstration is important. So these are the common things that they are going to ask you in the cardiovascular system examination. The pulse, the blood pressure, the JVP, the inspection, palpation, percussion of the heart, and the technique of auscultation. You have to be very, very clear with this. There should not be any mistakes in this. Once you have done with all these examination techniques, let's discuss some of the MCQs that are related to this topic. So the first MCQ we have here, all of the following are true about S3. S3 is the third heart sound, except. So always remember, except means generally have one or two right answers, maybe all three right, one wrong. So you should carefully read whenever there is an except. Third heart sound is best heard when the patient in the left lateral decompressed position with the bell of the stethoscope. So bell is correct, left lateral is for the position because LVS3 is heard. So this point is correct. It's a normal finding in healthy young adults. Yes, up to the age of 40 you might find hyperdynamic state, you might find it. Above the age of 40 it is wrong. Patient over 40 it is abnormal and indicates enlargement of the ventricle. This is one point. So it is a sign of heart failure. We have already discussed S3 is always a sign of heart failure, so that is correct. The second is also correct. So what appears wrong is the third option. Now abnormal above the age of 40 is correct, but it does not indicate enlargement. Enlargement always the sound is S4. So whenever there is a hypertrophy, we get S4. So of these 3 or 4 options that we have, the wrong one is the third option. So that is what you have to remember. LVH, RVH produces S4. So enlargement produces S4 and S3 is a sign of heart failure. The next option or the MCQ you have here is pick the odd murmur out. So they have given you a combination of aortic regurgitation, mitral regurgitation, pulmonary regurgitation, tricuspid stenosis. Now they have asked you to pick up the wrong now. Now how do we pick about it? So if you want to, you have to know the murmurs. So in aortic regurgitation, the murmur you get is the early diastolic murmur. Mitral regurgitation you get is a pansystolic murmur. Pulmonary regurgitation, the murmur you get is again early diastolic murmur. Tricuspid stenosis, you get a mid diastolic murmur. So based on the timing, the option is mitral. Mitral regurgitation is a systolic murmur. Other 3 are diastolic murmurs. Whether they increase on inspiration, expiration, please remember aortic and mitral goes for the expiration, whereas pulmonary and tricuspid goes for inspiration. So based on that we can't differentiate. Whether they are diastolic and systolic, based on that we have already differentiated whether it is that. So the answer for this is mitral regurgitation because it produces a pansystolic murmur. A systolic harsh ejection type crescendo decrescendo murmur in an elderly male, a high pitched musical murmur in the aortic area radiating to the apex with a low volume pulse. So here we have a systolic ejection murmur. So ejection systolic murmur in the aortic area. That's what we are seeing. And there is a radiating to the apex. So apex also it's going to the mitral area also. And the person has a low volume pulse. So low volume pulse we have already discussed. It can be due to aortic stenosis or mitral stenosis. So most likely diagnosis here is aortic stenosis. Let's look at the option: aortic sclerosis, aortic stenosis, mitral regurgitation or pulmonary stenosis. Now based on an analysis, our diagnosis is aortic stenosis. Now why is it not aortic sclerosis? Now aortic sclerosis is a degenerative condition where you have the murmur of aortic stenosis similar, but there is no effect of it. The BP is normal, the pulse is normal, the patient doesn't have symptoms. Here they have given you that there is a low volume pulse. That means it is a hemodynamical change that is there, which cannot happen with aortic sclerosis unless it becomes stenosis. So the correct option is aortic stenosis. Mitral regurgitation, you get a pansystolic murmur in the mitral area. And pulmonary stenosis, you get an ejection systolic murmur in the pulmonary area and it does not radiate to the apex. So that is wrong. So the answer for this is aortic stenosis and it is not aortic sclerosis. Paradoxical split of the second arch sound. Now what do you mean by paradoxical split? Normally it is aortic coming first and pulmonary coming next. That's normal. Paradoxical is where P2 is coming before A2. Very characteristic. Conditions where the left ventricle has become very thick. That's a simple thing that you have to remember. Wherever the LV is become thick, the conduction through the LV is taking time, A2 will become delayed. So those are the conditions that you could remember. So here is again an except, so you have to carefully look for the options. Left bundle branch block, aortic stenosis, hypertension, aortic regurgitation. So LBBB, obviously, if the left bundle is blocked, the right has to get stimulated, LV has to get stimulated so much late, you get paradoxical split. Aortic stenosis, severe LVH is there, you will get paradoxical split. Hypertension, again there is LVH that is there, you can get paradoxical split. Now aortic regurgitation, there is no LVH, there is only dilatation, you don't get a paradoxical split. So the answer for this question is aortic regurgitation. Going on to the next option that we have, true statement regarding pulsus paradoxus. Now we have discussed about pulsus paradoxus already. Decrease in blood pressure more than 10 mm mercury on inhalation. It is not inhalation, it is actually inspiration, but that is correct. The paradox is that the pulse becomes absent. Again remember, though it is not a paradox, it is a normal phenomena. That's the fourth option they have given. It's a normal phenomena. Now why do we still call it a paradox? Remember, in patients with constrictive pericarditis, supposedly they take an inspiration, the blood pressure will fall 20, 30, 40 and the peripheral pulse may be absent, where the heart is still beating but the pulse is absent. That is the paradox. So the paradox is that the loss of the palpable pulse, that is correct. And we have described very clearly, it is classically seen with constrictive pericarditis, acute exacerbation of COPD or asthma. So those are the causes. Classically seen with acute left ventricular failure. That's a wrong option here. Acute left ventricular failure, the pulse that we get is pulsus alternans. That's what we see. Bounding pulses, wide pulse pressure, left heart enlargement and continuous murmur. Now, wide pulse pressure, we have got the causes, MR, AR, PDA, VSD. All of them will cause bounding pulse and wide pulse pressure. Left heart enlargement, will MR produce? Yes. Will AR produce? Yes. Will PDA produce? Yes. Will VSD produce? VSD produces biventricular enlargement, so VSD is less likely. Now, what is the option, MR, AR or PDA? You have to look at the murmur. They have written a continuous murmur, very pathognomonic of patent ductus arteriosus. Mitral regurgitation produces pansystolic, aortic regurgitation produces early diastolic, ventricular septal defect produces pansystolic. The continuous murmur is what is giving you the clue that this is patent ductus arteriosus. A murmur heard with a stethoscope partly off the chest is what grade? Now murmurs are graded, you know the Levine and Freeman grading system 1 to 6. Grade 1 is very soft, heard only by expert. Grade 2 is loud, heard. Grade 3 is very loud but no thrill. Grade 4, 5 and 6 have thrill. Now 4 is a loud murmur with thrill. Grade 5 is a murmur where you can hear the murmur with the stethoscope just kept off the chest wall. And grade 6 is where you can hear it without the stethoscope also. So with the partly of the chest is grade 5 murmur. Remember 4, 5, 6 all have thrills. This is for systolic murmurs only. The sound that is produced by the atrial systole against a stiff non-compliant left ventricle. So atrial systole, late diastolic event, non-stiff ventricle. So the sound that is produced, opening snap, ejection click, tumor plop, third heart sound. Now again remember, opening snap is an early diastolic, that is wrong. Ejection click is a systolic sound, that is wrong. Tumor plop, again it's an early diastolic. S3, again where is S3 heard? Early diastolic. Now here we are talking about late diastolic event. So what is this? Sound that is produced at the atrial systole is S4. The answer for this is S4, and see in this option there is no S4. So none of the above is the option. So be careful when you see none of the above may also be a correct option. Here atrial systole on a stiff ventricle produces S4. None of these is correct. Hand grip increases all these murmurs except, this is a very important question that you have to remember, AR, MR, VST. All these murmurs increase on hand grip. The only murmurs which do not increase on hand grip or decrease on hand grip is HOCM and MVP. Now these are dynamic compressions. Okay, remember HOCM, hand grip, ventricular volume will increase, the obstruction decreases, so decreases the murmur. MVP, hand grip, you will have a vasodilatation sort of effect, murmur effect will decrease. So HOCM and MVP are the murmurs which decrease on hand grip. That's what you have to remember. Standing increases the systolic murmur of what? Please remember, when the patient stands, the blood flow to the heart will decrease. So the normal things will decrease. MR, TR, AS. These are standard diseases. They decrease on standing. Whereas opposite to that, HOCM and MVP. When you stand, the volume of the ventricle decreases, obstruction will increase. MVP and HOCM are dynamic obstructions which behave opposite of normal. So MVP and HOCM are the ones which increase on standing and they decrease on isometric hand grip. Please remember this, very, very common questions that are asked. Now we have described the various murmurs. Now which of these murmurs require evaluation? A systolic murmur grade 2/6, diastolic murmurs, continuous murmurs, murmurs with accompanying symptoms. Out of which of them need evaluation? Please remember, murmurs with accompanying symptoms definitely require evaluation. Continuous murmurs definitely require evaluation. Diastolic murmurs also require evaluation. Now, systolic murmurs require evaluation when it is more than grade 3/6. 2/6 could be a innocent murmur. Remember the soft systolic murmurs, 2/6, no thrills, very soft, may be functional. You need not evaluate a systolic murmur of 2/6. A systolic murmur more than grade 3/6, diastolic murmurs, continuous murmurs, murmurs accompanying with symptoms, we have to evaluate. So these are the common MCQs that are asked. So in today's session, we discussed various clinical examinations pertaining to the pulse, the blood pressure, the JVP, the apex and the parasternal heave, the cardiac percussions. We discussed it in detail. So these are very, very important signs that you have to demonstrate. You have to practice on your patients and then learn the skill. Also, you have to auscultate for the various sounds and identify the murmurs, identify the additional sounds, OS or clicks. All these things you have to identify. Only then can you understand about cardiology. But please remember, auscultation is not so very important technique. Auscultation, you can miss certain findings maybe, but on inspection, the pulse, the BP, the JVP, you should not be able to miss. So these are very, very important things which are going to be asked for you in your practicals and in your OSCE also. Students, in today's session, we discussed about various techniques of demonstration that are going to be asked in the cardiovascular system. Hope this session was clear. Thank you.